is, a first pilot study. Of course, we screened quite a lot of patients and we had this discovery and confirmation set up. But I think there are, in terms of moving this forward, and we're already doing this, is really to consolidate and better understand the prevalence of the antibody as well as the associated clinical syndrome by screening larger cohorts. And we have started to do this, and I am also looking forward to have colleagues around the world join us in that effort to carve out the clinical phenotypes. But I think based on the current discovery that we have and the fact that MOG-IgA is associated to patients with a clinically distinct syndrome, that is frequent myelitis, brain stem syndrome, rather less frequent ON, this does argue that this may serve as a novel biomarkers for patients with double seronegative, meaning ApoE4 IgG and MOG-IgG negative CNS demyelination. And of course, we have, as I mentioned before, there seem to be overlap with core clinical features of MOGAD or NMOSD, which already helps us now narrow down a little bit on what kind of patients we would like to screen in the futures. But of course, it brings us also to the challenge, right? So we developed this assay over quite some time in the lab and benchmark it with positive antibodies. So I think this will have to, also other centers will have to establish the assay, and then we'll have to be very careful in not randomly screening all sorts of patients, but really doing an informed decision on who has a higher pretest possibility to be positive, and then test them and then see if the clinical phenotype that we had in this discovery cohort actually holds up.